Welcome, everybody. We'll go on and get started. Thank you for logging on to our CTSNet Global COVID Grand Rounds. My name is Tom Nguyen, and I'm a cardiac surgeon in Houston, Texas. I'll be moderating with Dr. Joanna Chikwi in Los Angeles and Dr. Brian Mitzvin in New York City. This meeting is being sponsored by CTSNet. 4 months ago, COVID was not yet a household name. Some even considered it a hoax. In that short amount of time, the coronavirus has changed the world as we know it. We now have at least 1 million confirmed cases worldwide, schools are closed, economies are struggling, and hospital beds are full. We, the healthcare providers, are at the front line and at the highest risk, and as a byproduct, we also put our family and friends at risk. Yet there is still so much we don't know. In times of unknown, we need to rely on our friends and our global community. Today, we have a group of international speakers who will share their experiences and personal insight, as well as an international audience to learn from one another. During this session, we encourage you to make it interactive and submit questions in the chat box below, or via Twitter, #CTSNetLive. You can also direct message me on Twitter @TomCWin. All unanswered questions will be circulated amongst our speakers and posted on CTSNet. We also encourage you to invite others to join this meeting. My co-moderator, Dr. Brian Mitzvin, will now present a poll question.
Good morning, good afternoon, good evening, everybody from around the world. My name is Brian Mitzvin. I am a thoracic surgeon with NYU Langone Health. We're going to start off with a couple quick polls to get a feel of what everyone is experiencing. You should see a poll pop up onto your screen. For those that are experiencing the pandemic at full force, and even those that are just starting to prepare, we want to know what your single greatest challenge has been. Has it been the high number of COVID admissions, your inability to predict the time of the surge, lack of testing, lack of PPE, lack of ventilators, canceling your elective cases, staff illness and isolation, or other? We'll give you about a minute to respond. And you all should be able to see the participant count now. In case anyone's curious, we have nearly 1,000 people logged on viewing our grand rounds. So thank you everybody for joining. All right, I'm going to end our poll. And it seems to be a mixed response. You should all be able to see the shared results now. And I think it's the unknown. People are where we have a significant inability to predict time and size of the surge, but we're going to get started with our talks now. I'm going to turn it over to Dr. Chikwi from Cedars-Sinai in Los Angeles.
So welcome everybody. My name is Joanna Chikwi. I'm the chairman of cardiac surgery at Cedars-Sinai in Los Angeles. And I'm welcoming Dr. David Nabarro, who's actually going to help us with the question that was the most challenge that's been indicated in the poll, our inability to predict the time and size of the COVID-19 surge. Good morning, Dr. Nabarro. You are speaking to thousands of cardiothoracic surgery teams around the world today. We are faced with challenges that range from providing critical care to the sickest COVID patients to providing critical cardiac and cancer surgery through the pandemic. Thank you very much for joining us at our first Global Grand Rounds. For those of you listening, Dr. Nabarro has served in leadership roles at the World Health Organization and United Nations for 2 decades, including chairing the advisory group on reform of the World Health Organization's work in outbreaks and emergencies, and special envoy of the United Nations Secretary General on Ebola. He is special envoy to the World Health Organization on coronavirus, and his topic today is "We're at the front line. How do we protect ourselves?"
Thank you very much indeed, Dr. Chikwi. Just greetings, everybody. I'm anticipating being on the stage, in inverted commas, i.e. talking for about 10 minutes. And if there is anything wrong with that, I hope that the organizers will tell me to shorten or lengthen. Secondly, I'm probably going to have to slip off quite quickly because I'm in a little bit of a tough day today. And I'll explain a little bit more about my own view about what's happening, which will perhaps show you why I'm sort of in a constant rush at the moment. Just as some of you saw when we saw the pictures at the very beginning, what we've seen in the World Health Organization since this all started is an extraordinary exponential increase in the numbers of cases. So the key figures are that the virus seems to have an R0 of between 2 and 3, and that's pretty high. That means that the outbreaks expand really, really fast when they get started. Secondly, in Wuhan, the case fatality rate was between 1% and 2%, based on an understanding of the denominator, which may well have been slightly wrong, and I'll tell you why in a minute. But what was clear from the Wuhan experience, from experience in Singapore and in other markets, is that this capacity of this virus to kill depends very much on the capacity of health services to treat those who are critically ill. The approximately 15 to 20% in many series that do display symptoms. And so we are dealing with a situation where we've got a high R0, highly communicable disease with a pathogen that has a significant mortality rate, very much, as you all know, in the older and comorbidity community. So where's it going? Well, what we saw from the early stages was that if this is unchecked, it's capable of doubling at the rate of once every 2.5 days. That's a very rapid exponential rise. You get 8 times increase in the size of the problem in a week. You get about 40 size increase in 2 weeks, 300 size increase in 3 weeks, 1,000 times in 4 weeks, and it goes on speeding up. So what this showed us very early on was that the only way to prevent outbreaks becoming massive and explosive was to act quickly to suppress them. And by quickly, we mean within days. Within days of finding a case and seeing the first chain of transmission emerging, go in really fast and isolate those with the disease, trace their contacts, and then quarantine their contacts, ideally isolate them. And then, of course, you suppress rapidly, and the problem is just not at all serious. But if you wait a couple of weeks or even 3 weeks, you have absolutely massive outbreaks on your hands with utterly overloaded health personnel. You've got all sorts of problems with keeping safe and big surge of virus, particularly as we know now, as I'm sure you all know, that the greatest viral load and the most likelihood that droplets contain virus, even the chance of aerosolization, is in that 2 days prodromal period when typically people feel really rotten and they lose their sense of smell and taste to a degree before they develop their high fever, dry cough, tightness in the chest, and shortness of breath. And then, depending on how much comorbidity they have, they either go straight into needing care because they are affected by their other diseases, or it's a longer progression, and for a very small number, they actually develop pathology due to the virus itself, with alveoli walls getting thick, a very great increase in lung resistance, and all sorts of problems in keeping them going. So this very rapid spread was becoming clearer and clearer to us. And we were saying to governments everywhere, don't hang around. If you just get one case, mount a massive cross-society capacity for being able to identify the cases, pick up the chains of transmission early, suppress them really robustly, and do it very effectively, and tell everybody you're doing it, and get all of society knowing that this is an unseen enemy that is capable of causing enormous problems. But if you catch these outbreaks early, you don't have a problem. And of course, to do that, you need to be able to test for virus, which means you need PCR. And we've had all sorts of problems in many nations with the lack of ability to do the PCR work. And not only is that affecting finding the early outbreaks and suppressing them, it's also affecting our ability to make sure that health workers know their COVID status, and even to ensure that we have some idea of where the virus is in communities. So we've been really hampered, particularly in Europe and North America, because the basic and essentials for this public health function and what we do with any communicable disease of detect, isolate, find the contacts, quarantine, and then isolate them if they're sick, that sequence has been very, very hard to do. But it's also been hard to do because governments have somehow forgotten what happens when you get exponential increase in numbers with an infectious disease. I say governments, but of course, as many of you know, we're on this grand round from Singapore, from South Korea, from Taiwan, and from mainland China. And we don't refer to Taiwan as a country in the UN, but I'm referring to Taiwan as a geographical entity for this purpose of this call. What we're hearing is that they learned from the experience of SARS. They knew what was coming. SARS, the coronavirus, 2003, they knew that they had to get organized and active quickly. They knew that if they did that, they could suppress. So why am I saying all this? Answer, because it's abundantly clear to me that any government that wants to reduce the risks to health personnel has to treat this virus extremely seriously and get active and on the defense in communities from the first moment cases appear, which means having a very widespread honeycomb of public health capacity in place, ideally supported by testing. So if you haven't got the test, you have to use symptoms in order to suppress fast. Because if you prevaricate for any reason for say 2 or 3 weeks, then you get the kind of situation that many of you colleagues are having to deal with, where you have large amounts of COVID. So protecting health workers on the front line is firstly about suppressing outbreaks the very moment they start. And the reason for saying that also is that I don't think this virus is going to go away quickly at all. We're not going to have a vaccine to be able to immunize the world, but certainly within 18 months. Why? Because anyway, coronaviruses are not easy to develop vaccines against. Secondly, the whole process of testing efficacy and safety is going to take ages. And thirdly, to get mass implementation of a vaccination program across the world, even if we piggyback on other vaccination activities, is not going to be easy either. And there will be people who refuse. We're just getting that everywhere. So we need to make sure, every health worker needs to make sure that every government understands that to protect them, the most vital thing to do is to have the early detection, isolation process fully organized, ideally supported by testing. Thank goodness there are new quick virus tests coming on the market now. So as we speak, this rapid acceleration is beginning to slow. Why? Because more than 1/3 of the world has been placed under lockdown, which is a natural thing that you have to do if you're not able to do this rapid identification and suppression. Then you have to introduce lockdown as a way of reducing opportunities for transmission. And there's evidence that the lockdowns in Europe are beginning to be effective. Some of you will beginning to be seeing the numbers of people coming and crowding into your hospitals and overloading your ICUs are beginning to reduce in Italy and in Spain. We're not so sure what's happening in the UK. France has been very lucky, I think, in that they've managed to localize their disease in various places, but they've got big problems in the northeast and north of Paris. And then, of course, in the US, we still have very much a rapidly expanding pattern of pathology and some very serious situations in a number of centers. And we expect that is going to get worse over the next 2 weeks or so. Now, inside all this, I have to stress that it's also going into poor nations super rapidly. And in these poor nations, even though they've imposed lockdowns, they have got big problems. So I come to the most important part. Health workers are most at risk. There are big stories of health workers having to go to work, not being able to protect themselves because there is a major failure in PPE. Virtually every institution is stockpiling, and we are trying very hard indeed in the World Health Organization with others to try to find ways to cope with the market failure and to protect supplies for health workers, to try to stop people taking N95 masks and other equipment, people pilfering PPE and selling it on black market and so on, because we think that protecting health workers is the #1 job. And we don't have a magic solution to the market failure in PPE. And so I will keep working on that if I can. Secondly, I want to say that with regard to the situation of health personnel, I am working extremely hard to make certain that in poorer countries, there are tests available for health personnel and there is PPE available for health personnel, because at the moment we're seeing enormous numbers of reports from poorer nations that health workers are having to do their work without the necessary protection. Last word, the World Health Organization does not like making recommendations about how to deal with a problem like this with substandard capacity. For example, how do you cope with dealing with the detection and isolation if you haven't got virus tests? How do you protect yourself as a health worker if you haven't got PPE? And so I will say that I've been talking to the WHO Director General about this. I've just seen a question come up on the chat, and I want to say something to you all. Every person in the world is the concern of the World Health Organization, but decisions about the membership of the World Health Organization and of the United Nations generally come from the member states who own the World Health Organization. And there are major debates between the member states about which entities should be inside the World Health Organization, but I, as a public health professional, am not able to comment on membership issues. I've been asked to on many, many occasions. That, I'm afraid, has to be the concern of national governments, and they make the decisions and we operate within that framework. Thank you very much indeed. Back to you.
Dr. Nabarro, thank you very much for an incredibly valuable oversight. I hope you have a few moments to field questions. I'm glad you can see the chat. Some of the questions have really focused on the practicalities of protecting team members and family. One question from Turkey: should healthcare workers that are working in COVID units isolate themselves from their families when they go home?
Thank you very much indeed. The way in which WHO is advising on these kinds of questions is inviting everybody to think through A, risk, B, context, and C, consequences. Obviously, in each setting, the nature of the risk will vary. So if a healthcare worker is dealing with a great deal of virus and at a very high risk and is unsure as to the quality of the protection that she or he is able to maintain, we know it's always a team issue, the degree to which we can be protected, then obviously that's a worry. If the context is that at home if the context is that there is an awful lot of difficulty associated with navigating between home and work, and uncertainty also, you might pick up the disease as you're traveling to and from work and all that stuff, then the context is hugely important. I know of many health workers who have got their infection, they believe, outside the hospital in the community, and they therefore get disturbed about that. Number 3, consequences. If you live in a very tight place and you've got old people in your home and your elderly relatives, for example, and you're super worried that you might infect them, then you have to take that into account. I'm hearing of large numbers of health workers who are telling me that they're staying in hotels or they're staying in other accommodation in order to protect their families. And then I think that it obviously is a personal decision, but increasingly I'm hearing of people doing it.
Dr. Nabarro, you spoke to the shortage of PPE. People are coming up with creative solutions to try and address this. Where can healthcare workers get authoritative and accurate advice as to what is the best way to obtain PPE, or improvise it if you don't have access to it?
So with colleagues in the World Health Organization, the first thing, as I mentioned, was that we've been trying to work with manufacturers, logisticians, and others on trying to actually increase manufacturing capacity. We've gone to the private sector to seek very large amounts of money in order to invest in extra capacity, and then to try to establish much better ways of getting adequate supplies up and then protecting supplies for those who most need it because of stockpiling, which is a natural reaction in a situation like this. But yes, creative solutions are necessary. So together with the International Federation of the Red Cross, and colleagues in WHO, much to the concern of colleagues who say we should not do this. I want to stress, not in the WHO, but outside in the wider community. We are trying to come out now with what you do if you haven't got PPE. We haven't got there yet, and it will take, I'm afraid, a day or two, because it's going to need an awful lot of debate between people on the different alternatives. But please do watch this space. And if any of you do find some stuff on the internet or whatever that you think is reasonably useful, please don't hesitate to send through the organizer of this event, send me references, because we are checking out all the different ideas that are surfacing, either for alternative masks or for alternative PPE, as well as for new ways of doing ventilators with do-it-yourself kits and the like, because we're realizing just how important it is right now with so many health workers all over the world who are not protected.
Thank you, Dr. Nabarro. One final question, as I realize that you are limited on time. Could you possibly speak to the impact of this pandemic in developing countries that do not have the ability to social distance or access to PPE or the advanced therapeutics that we have?
Thank you very much indeed. As somebody who's worked for most of my life in Southeast Asia and in Africa, I have been particularly concerned, thinking back to the different hospitals in which I've worked, how on earth are they going to cope? Thinking back to the communities, how they're going to cope. And you know, there is just going to be no simple solution. I mean, we are currently actually hoping that it will turn out that in hotter climates, that the viability of this virus in droplets is much, much less. We're currently hoping that with the different age structure in developing countries, the mortality rates will be much less. We're also hoping that because of concomitant infectious disease or BCG immunization, the cell-mediated immune system is better primed, and therefore that will also reduce impact. But you know, we just don't know. And all of you know that with a virus like this that plays around with different aspects of what happens at cell membranes, it's quite possible that there will be unexpected consequences in people with other pathologies in poorer countries. So when this gets into a township in South Africa, or a favela in Brazil, or a very tight density urban population in India, and it's already started, what we anticipate is the following. People will not be able to isolate from their families. Whole households will have to be isolated. In many cases, people will not be able to isolate their households from others because they're so close together. So that will mean sections of the community will have to be isolated. We had to do this in Ebola in West Africa in 2014, and there are very serious social consequences with efforts to isolate communities. We will need to do this through very careful dialogue between those who are responsible for maintaining security and law and order on the one hand, and those who are responsible for ensuring people's well-being and their rights are realized on the other hand, because there are real risks inside all this, especially when it's done at local level, and it'll be done properly, I'm sure, but there are risks of people's personal liberties being infringed, and we are very much watching into that because we just perceive that this could be really problematic. And this will go one stage further, because I think we will find that there will be parts of the world that if they are not able to deal with this COVID, will remain off limits for international travelers, at least coming from them to the rest of the world for some time to come. So that's why our main focus, everybody, is on establishing this community-based capacity for detection and isolation and interrupting transmission, because in the end, that is what we need for making sure that you are safe in when you're confronting the virus, and that people will be able to travel to and from these countries in the foreseeable future so that economies can restart. What we don't want is more of these lockdowns because of their economic and social impact. Thank you.
Dr. Nabarro, thank you so very much. Tom.
Thank you, Dr. Barrow, so much. We're respectful of your time. We have over 1,200 participants from around the world watching. You know, one of the things about COVID is a lot of people compare it to influenza and say it's like influenza. At some point, everyone's going to get it if you don't have it already. we have Dr. Marsilio Tavio, who's the president of the Italian Society for Infectious Disease, to give his insight on this question. Dr. Tavio.
Hello to everybody. Can you hear me? Okay.
We can hear you.
Okay. Thank you for the kind invitation and also for the opportunity to share with you some issues about our experience in COVID-19. Actually, the first question is in continuity with the title you gave me. And let me see. Okay. To go
You should be able to scroll through your slides now, Dr. Tavio.
Okay, I'm trying. Okay. Oh, sorry. I have some problem.
Okay.
The second slide, please.
Yep.
Could you give me the second slide? Well,
if on your screen, Dr. Tavio, you just hit click to control the screen, and you should be able to control it.
I don't have the control of the screening actually.
Okay. I can control your screen. Just let me know, and I'll cue it in.
Okay. So, the second slide. Okay. Is COVID no more than a slightly? No. Okay. Actually, we've never seen a flu like this in the recent year. Probably you too. We have to remember that the case fatality rate of COVID-19 is exactly the same of Spanish flu in 1980, and we know the history and how many people have died for Spanish flu. The next, please. Okay. Okay. Well, if we look at the mortality rate, we have to interpret the data with caution because actually in Italy, for instance, last year we observed 8,000 deaths. That is half what we observed now for COVID-19. So what makes really the difference is the case fatality ratio. The next one, please. In this, well, in this slide, we can see the big difference between SARS-CoV-19 and flu and seasonal flu in terms of case fatality ratio. And the difference could reach 3 log, and this is very the heart of the problem. Well, the next one. In this slide, we can see the 2 cures of the last season of flu in Italy. And we can see a slight difference, a slight deviation between the curve of 19 with respect to 18. It's possible that some COVID-19 could be hidden in the difference between this curve, but is in terms of thousands of people, not certain in millions of people. Then in the next slide, we can see our situation. We are entering a plateau phase. We have to be cautious because it's possible that other outbreak comes out in the next future in Italy. So we have to be cautious about the interpretation of this situation. But in the next slide, we can see a study from England in which the attack rate for Italy, the next please, the attack rate for Italy is calculated in terms of 10%. That means that in Italy, we could have, next slide. The next, please. Next slide. 5.9 million people infected by COVID-19. Actually, this is a huge number. And of course, if in Italy there are 5.9 million of COVID-infected patients, where is everybody, or where were we actually to be unnoticed, a so great part of the population. The next issue I want, very brief, I want to share with you is about diagnosis. The next slide, please, Tom. Okay, about a lesson, a hard lesson we can learn from Italy. Next, please. We probably applied a model that was not valid in this situation, or I mean the SARS model, SARS-1, in which, next slide, in which it was very important consider the epidemiologic criteria to make a diagnosis of suspected case. The next, in both situations, in an area where a person-to-person transmission were absent, the next, please, Tom. Rather than in an area where person-to-person transmission was being documented, in both cases with SARS-1, it was important, the epidemiologic criteria. In our situation now, absolutely is not important. What is important is, next please, is the early diagnosis. The early diagnosis. In Italy, we performed so far 500,000 nasopharyngeal swabs, and we think is not enough. We needed much more swabs to make early diagnosis. That means 1 every 12 resident, 1 every 5 patient is not enough to recognize an epidemic in the first phase of the dynamic. The next slide, I think, is the only a suggestion: cardiovascular system victim or killer. Actually, this is a unique occasion to study the relationship between the virus and the cardiovascular system, especially the heart. As you know, the involvement of heart is quite uncommon in a flu seasonal like syndrome. We have a suggestion that this is a particularly frequent situation in COVID-19. So it is also a good occasion to study this relationship and to prepare a set of biomarker and clinical tools to intercept this kind of disease. And I stop here. Thank you.
Thank you, Dr. Nabarro, Dr. Tavio. I want to ask you a couple of very practical questions as an infectious disease expert. So let's say you're a healthcare provider and you don't have a mask on and you're exposed to a patient that's COVID positive. When you go home, should you be wearing a mask, and what can you do to protect your family? With the background that up to 50% of patients who have COVID positive are asymptomatic, so you might feel okay, but you might be COVID positive. What are your thoughts?
Healthcare workers, well, actually, our policy is that an healthcare worker that comes in contact with a person with COVID-19 have to wear PPE also at home, because we think that is extremely important to avoid contact at least for 14 days. This is our policy.
Should all healthcare workers be routinely screened for COVID, assuming we have enough tests available?
Actually, we don't have such a possibility now. We test healthcare workers only if they become symptomatic for COVID-19. And at this point, we can test them, and to avoid the contact with the patient and with other healthcare workers.
Thank you. And one last question that comes from our Twitter feed. Do you know the sensitivity and specificity of our current COVID tests?
Well, specificity of current COVID test, molecular test is high. Sensitivity is about 90%. So we need sometimes to test 2 times the patient. And in a particular case, we treat a clinical case such as it was positive. Okay.
Well, Dr. Tavio, again, we appreciate your time and your willingness to join this international community. I'm going to hand the microphone over to Dr. Brian Mitzman, who is going to have a poll question and introduce our next speaker. Brian, thank you, Dr. Tavio.
Thank you.
Thank you, Dr. Tavio. Thank you, Tom. In the interest of time, we're going to skip the poll for now, but we'll likely come back to it a little later. As healthcare workers, we are at extremely high risk for contracting COVID-19. Our next speaker is Dr. Isaac George. Dr. George is a cardiac surgeon based in Manhattan. He's an associate professor of surgery at Columbia University and the surgical director of the Heart Valve Center. He has a very unique and personal talk planned for everybody. I'm a cardiac surgeon and have COVID-19. Now what? Tom's going to get the slides going. Dr. George, thank you.
All right, thanks everybody. Can everyone hear me okay?
Yes.
Thanks Tom, Joe, and Brian for the opportunity to speak. I'm a cardiac surgeon at Columbia Presbyterian in New York. And the title of my talk is, I was COVID positive, and now what? Can you guys see slides? There we go.
And you should have control, Isaac.
Okay, can you start the slides, Tom?
Sure.
Okay.
I'll go ahead and control your slides, Isaac, and just tell me when to advance.
Okay, next slide. So in the second week of March, we had gotten aware of what the COVID situation was potentially going to be, and we were quite concerned. We sent an email out to the group, our surgical group, trying to organize ourselves, and it was clear that we were all pretty worried. We thought, this is serious, let's get ourselves together. We even brought up the possibility of the Javits Center coming up next. And other concepts such as hospital zones, specific hospitals specifically for COVID, staggered teams next. And, you know, and you can keep clicking through. Next. And so we were quite concerned, and we understood that this was coming. Next. So not long after that, I started to have some symptoms consistent with COVID. Next. So on Sunday evening, I started with a mild cough. Next. On Monday, I started developing fevers, and I had what was really malaise, and I just kind of slept on the couch at that point just to be away from the rest of my family. Next. And on Tuesday, I started my isolation. I left the apartment. I had fevers up to 101. The 2 symptoms that were really the worst were severe myalgias and a really bad headache. Next. And so for the next few days, it kind of continued on the same severe myalgias, headaches. I had fevers, and really at night, it was sweats at night where I would really drench the sheets. And the rest of the symptoms were very constitutionally similar to what you have with the flu, but worse. Next. And then it slowly started to improve. By Saturday, I stopped having fevers. My test came back positive. Everything was clinically improving. And so next, by 6 to 7 days from the start of symptoms, I had much more energy and everything had basically gotten better. Next. And I went back to my apartment. I moved back home with the family on Monday. And as was recommended, I was wearing a mask at home. Next. So the next question was, when do I go back to work? You know, the hospital and the CDC says you can return to work 7 days after the onset of symptoms, as long as you're afebrile for 72 hours. Next. And you can see here that this shows you a schematic of when you're potentially still shedding virus. And for somewhere between a no symptom and a mild symptom situation, I'm somewhere between 14 to 21 days from the onset of symptoms when I'm shedding virus. So regardless, no one at the office was really that excited for me to come back between 7 and 14 days. So I stayed home, and then I came back really about 14 days after the onset of symptoms. And again, I've been feeling very well, thankfully. Next. So where did I get it? This is the million-dollar question. Next. I mean, the most obvious answer is I got it at the hospital. You know, we were very early in the course of all of the situation, and there were only a few patients in the hospital at the time, although we did have much less awareness than we did now. Next. Maybe it was the subway. I take the subway every day. It's almost impossible to get, 6 feet from people, much less, 6 inches really, which is how the subway runs. Next. But I actually think where I got it from was a gift from my barber. Next, I had a haircut on Thursday. Next, you can keep clicking through. My barber is from Brooklyn, from one of the most affected parts, and he had a mild cough, and my symptoms started about 4 days after my haircut. And I suspect I actually got it from my barber, of all places. So, next. So where have we done a great job? We've done a great job in a lot of different areas. At NYP, we decided we're going to stop doing elective cases 3 weeks ago, which is a huge step. We did PPE planning very early on, and we mobilized and strategized. And so we've had almost no shortages of PPE. We started getting extra spaces early. We made our ORs ICUs. We've been moving our floors and becoming ICUs for 3 of our floors with full vent capacity. So we've expanded our ventilator ICU capacity now, almost 5 times. And then we've also reorganized our staffing units. Next. From the Department of Surgery, we've been very informed. We've had bi-weekly communication. We've all been on the same page, and we've all been helping each other out. Next. In terms of the Valve Center, the same thing. We've had frequent teleconferencing. We've had almost a virtual transition to a telehealth clinic, and we've actually been able to maintain that clinic, which has been very important for patient continuity. Next. But obviously, and I think one of the things that you probably have seen, which has become viral, is Craig Snet's email daily updates that have been really poetic and really uplifting. And it also gives a sense of realism to what's going on from our situation. Next. And you can see our senior leadership from our VP to our CEO of the hospital has really been on top of this and really been one of the reasons that we've been able to limit the situation. And I think we've been really in a world-class situation because of these leaders. Next. And one thing to remember, they're all MDs. They were and are practicing MDs, and I think that's a really important thing that has kept our healthcare workers first and foremost in mind. And the mantra really has been, we're going to do the right thing, and then we'll deal with everything else afterwards. And I think that's a fundamental philosophy of MDs, and I think that's one of the gifts of being a doctor as an administrator. Next. But we can always do things better, whether it's at the federal level, the CDC level, at a hospital level. Our mask protocol was always a moving target, and it went from no mask to needing a mask, next, to rationing masks, to N95s. And that's one of the things that, next, you can keep clicking, has always been something that's been in flux. Next. And I think there is some understanding that maybe a mask does help, whether it's in the general population or in the hospital itself. Next. Next. So next, we've always had some ambiguity in terms of what the recommendations for isolation is for patients, for healthcare workers. Next, we're always trying to figure out what the true procedure precautions should be, whether a patient is pretest probability high or low for COVID. Next, should you wear a surgical mask? Should you wear an N95? Next. And then trying to figure out what isolation of rooms and sections should be, whether it's a clean section, a clean unit, a dirty unit, has been difficult. And trying to get that enacted when you get a surge of patients is always hard. And most importantly, we've not really had enough testing for healthcare workers, and clearly understanding and knowing that the healthcare worker is the most important part of this piece, this diagram. And if that falls apart, then everything falls apart, is important. And so I think really being able to test our healthcare workers and understand their status is really important. So the US is singularly dysfunctional in regards to PPE. You see that, wearing some kind of mask as opposed to a true hazmat mask, next, is what we're facing with. The protective gear at some hospitals in some countries is extraordinarily high. Next. And some places even have true hazmats. I think this was from India. And next, but we've been a little behind, and we've effectively become the boroughs of PPE in the United States. And I think we're working on changing that, and that's very important that we have to change. Next. So where do I go next from here? It's really ICU work, whether it's in our main ICU or our OR pods ICU, doing any procedures that need to be done. But there's a clear understanding that this is going to take a few months to rectify. Next. And, emergency cardiac surgery, next, is really pretty low on the list, whether it's a dissection in a young patient, emergency cabbages that can't get PCI, valve surgery that's not amenable to TAVR, or emergency TAVR, valve and valve, or MitraClip. Those are all potential options. But when you have this kind of situation, you realize what the needs are for the hospital, and we do whatever we can. Next. So I think in conclusion, it's allowed me, these kind of situations allow you to reprioritize the things that are important in your life, and to understand them and to keep things in perspective. I think we're all in this together. We'll all get through this. Thanks very much.
Dr. George, thank you so much for sharing your personal experience. We got numerous questions from the audience. You had mentioned that your colleagues were not really thrilled about you coming back. When you did start working again, did you notice any specific stigma about your daily activities and what you were doing around the hospital?
No, not at all. It was, just making sure that the office is clean and everyone, understands that at that point I'm asymptomatic and I've probably cleared all virus anyway. And so, in some regards, with potential immunity, it becomes good. And so I volunteered and been able to do a lot. And I respect that, and I understand that maybe it's an obligation to do more.
Great. So you had also mentioned that the recommendation is to wait 7 days before you return to work, but you chose 14. What do you tell your patients who are getting sick? How long should people be waiting before they go back?
It's a good question. I don't really know. I think part of that's dependent on the fact that at the time we didn't have the same need that we have now. And I think if you need to come back as a healthcare worker and you're feeling okay, then potentially those recommendations are very reasonable. If you don't have a need to come back and you're not needed clinically in the hospital, waiting, an extra 7 days is also not unreasonable either. I don't know what the right answer is.
I have two last questions for you. Have you been tested negative since you went back to work?
No, we don't repeat tests.
Okay.
There is serologic testing that you can do for convalescent serum. You have to be 14 days out, and we'll start that process for me soon. But that's the only secondary confirmatory testing that you can do. It's not routine.
And the last question from our chat, which I actually think is a great question. Now that you've beaten COVID and we're glad that you're healthy again, do you feel empowered because you have some potential immunity, and do you think those who have beaten it should be doing more work on the front lines?
I think it's a reasonable question to ask. I don't know what the status of immunity really is, and I think you have to be able to confirm that, and I think you still have to take universal precautions. But I do think that down the line, when we're talking about a 6-month or a 12-month period where this is going on, that patients or people who have immunity will be in a different activity level and a different status to some extent. And so we have to, understand that those are unique situations and populations that maybe be able to do more. Certainly for surgery in high-risk populations or high-risk procedures, that may allow us to do more with less risk. So yes.
Great. Again, thank you so much for sharing your story. I'm going to turn things back over to Tom to introduce our next panelist. Thank you.
Thank you, Brian. And thank you again, Isaac. There are few countries that have been hit as early or as hard as Italy. It's a privilege to introduce our next speaker, Dr. Gino DeRosa, for a couple of reasons. One, he's in the heart of Italy, but also he also tested COVID positive. And the title of his talk will be Hello World, What Could we have done differently? Dr. DeRosa.
Thank you, Tom, and good afternoon to everybody. So if I can have the slides. Yes. The first slide. So as you mentioned, Italy is on the front line. If you can give me the first slides, I can give you an update of the Italian outbreak up to yesterday, with over 115,000 cases so far, with roughly 14,000 deaths that accounts for about 5.8%. As you mentioned, being tested positive, I was surprised to listen by Isaac that he has not been tested. I've been tested when I was still asymptomatic, just because I got in touch with the cardiologist during a meeting, and the cardiologist, the day after, developed some symptom. He was tested 2 days later, and he was found positive. So they tested all the colleagues that got in touch with him, and that's why I performed the test. The test was positive, so I was put in quarantine. And then I started to develop some symptoms after 6-7 days. And for 4 days, I had a really bad high fever, bad coughing. But luckily, I did not experience any short of breath, so I could stay at home. I was not going to the hospital. I didn't do a CT scan. And then finally, from the clinical point of view, I recovered. And tomorrow, I'm going to do the test, an nasopharyngeal swab, because you need at least 2 negative tests before you could resume your work. You can go back to the hospital. So I was mentioning about the updated Italian outbreak that you can see in the slides. You see about 6% of that. Now the number per day is slightly decreasing since the 29th of March, and hopefully the trend should still go in the lower part of the curve. Next, please. So you see Italy is a very long, thin country, and you see the vast majority of infected cases are located in the northern part of Italy. And now we're giving you a picture of 2 regions. Next slide, please. These 2 regions are the Lombardia and the Veneto regions. I work in Padua. Padua is in the Veneto region. Veneto has 5 million inhabitants. Lombardia, where Milan is, has 10 million inhabitants, so double size in terms of inhabitants. And you see the number of total cases in Lombardia has been over 46,000, with a mortality that is roughly about 15%, with nearly 8,000 deaths. And if you look at the test performed in Lombardia, this so far have been roughly about 7,000 tests. If you look at Veneto region with half of the inhabitants compared to Lombardia, so far we have 10,000 cases versus 46,000 with a 5% mortality because the number of deaths is 532. But the number of swab done is higher than the number of swab done in Lombardia with 7,500 tests performed versus 6,800 tests performed in Lombardia. So this could explain somehow the difference in terms of mortality. Now the question was what we could do something better or let's say something different. Next slide, please. And I go back to the issue of PPE. PPE was a problem at the beginning in Italy because the number of protection devices available for the health worker was totally insufficient. So definitely what we could have done better is to protect the health worker. I'm just giving you this date. So far in Italy, 80 doctors died. And probably the lack of PPE has been a problem. And that could be sorted out before. Next slides. But also when you compare the difference between the Veneto region and the Lombardia region is the fact that probably in Veneto, we have done more nasopharyngeal swab tests. So we could identify positive patients, put those patients in quarantine and increase the social distance. And also this could reduce the hospital admission because at the beginning, patient follow-up could be done by the GPs, providing that PPE were available for GPs because among those 80 doctors that I mentioned died in Italy, the vast majority were general practitioners who got in touch at home with patients that were already positive. And also the idea that has been done in Italy is to have specific COVID hospital, even though also in the general hospital, like a Padua University Hospital, part of the hospital has been dedicated to COVID patients, and therefore all the elective so that next slide, please. I think that we should already think about phase number 2, because now we have faced the emergency, but around the corner there is already phase number 2, and we should be prepared about that, because of course phase number 2 is not only a healthy issue, is an economical issue, and mostly is a social issue, because social distancing, of course, people are getting annoyed after a while to stay at home, not be able to go around. So very recently, we 150 professor in academic position wrote a position paper, a plea to the government in order to be prepared for the second phase, for phase number 2. And that means to evaluate the serum antibodies of patients who pass through the disease in order to certify that somebody is cured, and also to get the serum antibodies to be utilized in very sick patients, and also to be able to determine the prevalence of the disease. So what we can do better, probably we can do better right now. Thank you.
Thank you. Thank you, Gino. Again, we appreciate all the dialogue that's taking place in chat. We have about 1,100, 1,200 participants right now. Again, we encourage the dialogue. Gino, Europe is a dense area. Why Italy of all the countries in that area? Why do you think Italy became a hotspot?
This is a very good question. There are several hypotheses. One of the hypotheses, you know, that Milan is on the same latitude than Wuhan, and probably, you know, the PMI can play a role. The the number of industries in that area compared to other area of the country. So pollution, air can play a role, and that could explain why in that area, Milano area, was so high the incidence, the number of patients infected when you compare with other area from Italy, for example, the south of Italy. And of course, probably we made a mistake at the beginning because we did not isolate, we did not test people coming back from China because of working reason. And probably we paid high price because of that, because we were not able to test those patients, to test those individuals, and to be able to quarantine those people and to start with social distancing and so on.
Can you, we see these videos all over the internet and social media of Italians singing in the streets and from the balconies. Can you describe the general morale in Italy right now? I guess, are people optimistic? Are they hopeful? Are they depressed? What's the vibe right now in Italy?
That is a very, very good question, Tom, because when I mentioned phase number 2, I was mentioning the health issue, I was mentioning the economic issue, but I was mentioning also the social issue, because of course, people has been invited to stay at home. Social distancing has been taken very seriously in Italy. So people is not going out, just going out for shopping for food, that's all. No other opportunities, everything is closed, universities are closed. We are doing lesson through other devices, and school are closed and so on. So far, that's why you saw all those all those moving videos on the internet, on YouTube, because people trying to be reassured, having the possibility to have a sort of face-to-face from one building to the other building, from one balcony to the other balcony. In the next week, the social issue is going to be very critical, because this is also going to face a dramatic economical and financial crisis.
And in Italy, what we see and what we saw was the explosion in COVID cases that overwhelmed the healthcare system. And I imagine there had to be restructuring of the healthcare providers to take care of these patients. Can you describe a little bit some of the things that happened behind the scenes? So as you as a surgeon, are you having to work in the ICU? Are people's roles and responsibilities having to change significantly because of this? What guidance do you have?
So, there have been a lot of discussion regarding the fact that sometimes elderly people would not be intubated or not enough ICU bed or enough ventilator. This is, I would say that this has not been true, because the lack of ventilator has been an issue, lack of ICU bed has been an issue during the outbreaks, the worst parts of the outbreak. But I would say that finally, the national health system in Italy is very peculiar when compared to the United States, because everybody has access to therapies. You don't pay anything for that. So I would say that everybody, the system, the national system has taken care of every single patient, and nobody has been, let's say, declined the opportunity to be cured in the best way.
Do any of the other panelists have any questions for Dr. Gino Gerosa?
Sure. You're about 2 weeks ahead of us in the US and New York. What would be your advice to centers that are just about to face the peak stage of patients?
Sorry, Joe, but I couldn't hear you because the connection is really unstable. Can you say that again, please?
Yes, what's your advice to centers in the US that are about 2 or 3 weeks behind Italy in what we're facing?
That, as I mentioned during the last CTSNet, that social distancing probably plays the best role, social distancing. And so to stay at home, to be able not to get in touch with the other people, mostly to stay at home. That's the advice that we really learn from our experience. But I'm surprised that you are not tested, because I was surprised to hear that Isaac was let's say, symptomatic, it has not been tested, it has not been tested after he became asymptomatic, and he could go just back to work. I cannot go back to work. I know that tests can be false negative. We can discuss about that as much as you want. But really, if I don't have 2 consecutive negative tests, I will not be admitted back to the hospital again. And I think this is playing a role as well.
Oh, don't worry, Gino. If I have beers with Isaac, I'm definitely wearing a mask. So I'm not gonna hang out with him until he's tested again. Brian, do you have any questions?
At this point, I think let's jump into one of the polls that we've had saved up. So all the attendees should see a poll appear on your screen. We've all had very different experiences up to this point treating COVID patients, as we're all in different parts of the world. So how prepared are you for a surge in COVID-19 patients? Have you had less than 200 patients and you feel prepared for future increases? Less than 200 patients, but you feel inadequately prepared? Or are you already surging? You have more than 200 patients and you've been well prepared and you feel comfortable right now, or you have more than 200 patients, but you're inadequately prepared? I think everyone at this point knows the New York perspective with what we're dealing with out here. Joe, I think you guys are starting to ramp up out in LA. How are you handling it?
It's been very different to the New York experience, partly because we were able to learn from Italy and New York, and partly because we don't have mass transit, we don't really have mass housing, the population density is lower, and we shut down California very, very early. So since the middle of March, there's been really strict compliance with social distancing. So right now it seems that the community hospitals are filling up with COVID patients. There's a lot on the ICUs. We maybe have about 100 in-house, probably less than 20 ventilated, and we haven't seen a huge rise, but we wound down all of our cardiac surgery operating in March. We operated all of our elective patients from April that we felt couldn't wait 6 to 8 weeks. So right now we have no elective cases booked for the whole of April. We're just doing urgents and emergencies. We are doing transplants, status 1 and 2 for hearts. We test the donors, we test the recipients. We require 2 negative tests to do transplants.
Joe, can I say something? I'm surprised to listen that you are able to do transplant, because that is an issue in Italy, because all the ICU beds are devoted, to COVID patients. So it's really difficult now to find donors, because all the energy are absorbed by the COVID patient in the ICU bed.
I think that's absolutely true. And I think the East Coast, that's absolutely been critical, and it will become critical in the Midwest and West Coast. The other thing that happened very early on was, because of the social distancing, the lack of road traffic accidents, there was a lot less drug use. So effectively, we saw a real decrease in the number of donor offers. And then, as you say, as critical care beds and anesthesia resources get chewed up at donor sites, that will further impact things. But right now we're getting offers and we are transplanting.
Thanks.
Joe, you want to introduce Dr. Mihalovic?
Absolutely. Good morning, Dr. Mihalovic.
Hello, how are you?
Thank you so much for joining us. You're speaking to about 1,200 cardiac and thoracic surgeons and team members from around the world today. We're all faced with the challenges that you're very familiar with, ranging from providing critical care to the sickest COVID-19 patients to providing critical cardiac care and cancer care throughout this pandemic. So thank you for joining us at these first Global Grand Rounds. For those listening, Dr. Mihalovic is a cardiothoracic surgeon. He's president and CEO of the Cleveland Clinic, which is really uniquely positioned to give us a perspective here because of the size of its cardiac surgery programs and its global reach. His topic today is, when the COVID dust settles, what will be the global impact on economies and healthcare industries? Thank you very much, Dr. Mihalovic.
Well, thank you very much for having me, and thank you to all of you who have joined online. It's fun. I rarely do this, actually. It's been years since I spoke to my colleagues in cardiac surgery. So this is a nice opportunity. I wish it were under different circumstances, and I wish we were live, but it is what it is. So let me just, I'll probably speak briefly, and then if there's an opportunity to ask questions, I'll be happy to answer to the best of my ability. Obviously, the biggest question for all of us is, okay, how long is this going to last? How bad is it going to be? How long is it going to last? We all know that these answers are close to impossible to give with any degree of certainty. Very many countries and people who are online are currently deep in the battle, so to say, for saving lives of people who have been infected with COVID. Let me just share a little bit of a Cleveland Clinic's perspective. As you may know, we're an international healthcare organization. So we have a presence in the United Arab Emirates, at Cleveland Clinic Abu Dhabi. We're building our presence in London, and then a large national presence here in the United States, predominantly in our home state of Ohio and in Florida. So we've been watching the development of the COVID starting earlier than most U.S. health systems because we started to treat the COVID patients in Abu Dhabi and started the preparation, just like any large integrated healthcare system, to meet the surge. A fortuitous set of circumstances for us, based predominantly here in Ohio, is that we seem to be on the tail end of the wave that is sweeping the country, the world, and the country. So we have had an opportunity to put more time and effort into preparedness. We started preparing and we activated our incident command center in early January, while the pandemic was still an endemic and it was in China. So we have tripled our hospital capacity and the ICU capacity in anticipation of the wave. The other good thing for us being here in Ohio is that the measures of social distancing were put in place very, very early. We were one of the first states to go down that path, thanks to our governor. So we're seeing a, so to say, a flattening of the curve, at least the early signs of the flattening of the curve already. Cleveland Clinic is taking care of only about 110 patients with COVID, of which half of an intensive care unit. So that is where we stand. You know, I've been putting a lot of thought into what's the healthcare going to look like after this pandemic is over with, and as we also try to learn how to live with COVID or similar pandemics. And I will offer at least a few insights that I believe are relevant. I do view this pandemic, if there is a silver lining, as a catalyst for much and long needed transformation of healthcare. And let me just try to put a little bit of a systematic thought into this. When we speak about a complex topic such as healthcare at Cleveland Clinic, we always look as our role as providers or caregivers in four quadrants that are mutually interdependent. Obviously, patient, research, education always in the center. But we believe that we as an organization, individuals have a responsibility to take care of patients, but also to take care of fellow caregivers, to take care of our organization and its resources, as well to take care of the communities that we serve. We call it 4 cares at Cleveland Clinic. So let me just go through each one of those and how I believe, at least, those are going to look like after we weather this crisis. When it comes to the way that we provide care, let's just speak about a clinical care. I do believe that we're going to see an accelerated trend towards a care at home and a telemedicine. That strong trend in ambulatory care is going to be even more accentuated than before, and that the inpatient hospital care will be truly reserved only for those with the greatest need. There's absolutely no doubt in my mind that this trend that we're seeing already today is only going to be accelerated. As a point of reference, before the COVID pandemic, 2 to 4% of our visits were done through telemedicine platform. Currently, it's about 30 to 40% of our visits, and this is not going to stop. When it comes to caring for caregivers, this has been for a really, really long time an underappreciated factor. in the social life of many countries in which we take care of our patients, meaning that the importance of a healthcare profession and healthcare professionals in a social life has been, I don't want to say ignored, but hasn't been truly appreciated to its fullest extent. And I do believe that the importance of a teamwork, the importance of well-structured healthcare systems, and the importance of taking care of those of us who are there to help others will be appreciated more than ever as we get out of this crisis. Let's just speak briefly now about the future of healthcare in the hospitals, and I believe very many of you are interested in that aspect. When we take a look at what's needed to combat this pandemic, we can extrapolate that also into the learnings for the future. I am firmly convinced that integrated, not just large healthcare systems, but truly integrated healthcare systems that are going to use the power of their shared resources, both human, intellectual, space, equipment, to address the emerging needs in healthcare. That is going to be the model of the future. I do believe that we're going to see a decline in a number of independent, smaller practices, whether private practices or smaller standalone hospitals. And I do believe, just like after any major crisis, we're going to see fewer yet larger and better integrated healthcare systems. It has been my conviction that this is something that we needed to establish in the United States quite some time ago, because if you take into account most renowned healthcare systems in the United States, the largest academic medical systems, each one of us covers at the most 0.5% of market share, US market share. If you put the top 10 academic medical systems together, all of us together serve only 5% of Americans. So clearly, if we want to resurrect it, this is where it's going to go. I do believe that we're going to see a big changes in the ways that we're reimbursed for our activities, probably a greater role of a central payer, and that will depend largely about how the private payers also, how they participate in today's crisis. We really need to seek their greater involvement. Right now, they seem to be more on the sidelines. While there is a clear financial burden, operational burden that is being directed towards us as providers. And lastly, I do believe that we as healthcare providers, in order to provide better care for our communities, that's the fourth aspect of care, we will be going down the accelerated path of recognizing data-driven, continuous provision of healthcare, where we're going to seek a lifelong partnership between us and our patients. And I think we will need to meet their needs based on a large amount of data that we'll be able to collect and analyze, use digital technology in a much better way, not only to treat pandemics like this, but also very many chronic diseases that create 80% of the healthcare burden in every developed country. And that's yet another reason why large integrated healthcare systems that will have that analytical power will be the survivors and will represent the new model of healthcare, I believe, in very many countries across the world. So this is my view of where healthcare is going. I'll just offer one more perspective, and then I don't know if it's an opportunity to get questions from the audience. One big question that I do not think we have an answer to yet, I believe that we all need to think about is, okay, what is our exit strategy? When are we going to learn how to live with a pandemic like this without stopping the entire societal activity and economic activity? There's a very vigorous debate in every country of the trade-offs between stopping the economy and incurring substantial financial losses and trying to help those in need. I think that we all know and understand that we as a healthcare providers are not concerned just on the lives of one segment of the population. We're trying to take a look at a broader view, and a really important missing part in the public discourse is an understanding that a serious economic downturn and depression also results in a loss of lives. High unemployment, lack of access to healthcare, deferred care can result in a substantial losses as well. So we have to start to think about a public dialogue about how do we really balance the needs of today with the needs of a sustainable platform for healthcare delivery and social functioning down the road. So I'll stop here.
Thank you very much, Dr. Mihalovic. I think everybody would agree with you about the fact that this is going to accelerate the trend towards telemedicine, home care, and ambulatory care. I suspect that Cleveland Clinic feels it's probably the best prepared health system in the world to deal with this. So could you possibly speak to what measures, what strategies you used as an organization that the rest of us could learn from?
Well, I don't know if we're the best, but we're certainly putting a lot of thought into this. We're not perfect by any stretch of imagination, but we've been actively thinking about this for a really, really long time. I'll give you obviously the first glimpses of what we're trying to do when it comes to telemedicine. We have formed a joint venture with us and American Well last year that allows us to provide a second opinions of a Cleveland Clinic to 80 million of people across the world. Because obviously we do understand that we're always going to be limited in our ability to provide care to people if we try to do it only through physical entities, building hospitals and building ambulatory sites. It's going to be too slow, too limited. So digital technology allows us to scale it up. We cannot do everything by ourselves. That's the reason why we seek partnerships. But we have partnerships not just with American Well, but we have partnerships with, all the large IT companies, Microsofts and Googles of this world that are helping us to accomplish that. The transformation of care is core to everything that we do. Only 5 years ago or 8 years ago, Cleveland Clinic had very few internal medicine doctors, very few family care physicians. Now this is the largest component of our enterprise. We went from 40 to 600 primary care physicians over the course of 5 years, and from 50 or 25 advanced practice providers to almost 2,500 in the same span of time, because we're looking at how to change the pattern of the care that we provide. For COVID pandemic, a few things that we have started early. As I said, we started this in January. One is to make sure that we have, to the best of our ability, appropriate supplies. We have also put a lot of effort into understanding what are the projections of the curve, so that we can tailor our response appropriately. So we've done a lot of work with modeling, predictive modeling, artificial intelligence, and started following the natural curve of the disease in the pandemic early on. As a result, we have learned that we have to triple our capacity in order to meet the potential demands of our communities. And we worked with the worst case scenario. The number of different scenarios out there depends upon the spread of disease, effectiveness of the social distancing. What we've used in our model and what we subscribe to is the worst case scenario. By the worst case scenario, we have to triple our capacity. So we've put a lot of work in tripling our capacity. So we've gone from 2,500 beds to 8,000 beds here in Cleveland. Our health education campus is being transformed to a 1,000-bed hospital, which is going to be completed within the next 2 weeks. And we have put a lot of effort into reassignment of our caregivers. As you know, we have predominantly employed physicians in our group, and And that is one strength of large integrated healthcare system. We have, as we kind of turning down some part of activity, we have taken a labor from that part of clinical enterprise and started educating them and reassigning them to the areas that they will be needed to participate. So we have educational program, reassignment. A really important part is the patient, the caregiver support services, and I can go on and on and on. But those that kind of hit the that hits the major points. Taking care of space, taking care of equipment, most importantly, taking care of people.
As a leader of a huge organization, how do you balance the need to control the message and the ability of your employees and teams to speak out about things that they feel strongly about?
Communication is the key. Nothing is more important. I have been spending more time in front of cameras than I've ever had. I never thought that signing up for this job that I'll be spending so much time communicating. So this is how we do it. I communicate with the leadership of the organization twice a day, at 7 o'clock in the morning and at 2 o'clock in the afternoon. And this is an executive team and slightly extended executive team. I send written updates to everyone every single day with all the details of the work that we're doing. Every other day, there is a video message. Just recently, we taped a video message. I went to one of our intensive care units that is filled with COVID-19 patients, and it's dedicated for that, so we can speak with the team. We inform our board every single day as well. And I have told everyone that there is absolutely nothing that I know that is of relevance that the people in the organization would not know. Complete transparency. And then there is a dialogue. Every week we have a call with 350 leaders across our system in the entire world, where we exchange not only the reports, but also ask for feedback. So this is a lively dialogue. A few things that I've shared with everyone. I told them, it is not going to be perfect. It is going to be messy. Please be kind to one another, do the right thing, and we'll go through this together. We have a firm commitment to every caregiver at the Cleveland Clinic. We will not have any furloughs, no layoffs, and we'll get through this as one team.
Thank you. Brian and Tom, do you have further questions for Dr. Mihailovic?
I do. I have a question that I want to field from our chat channels. Again, thank you for joining us this afternoon. This is a practical question. The day-to-day operation of the hospital has changed from only a few visitors being able to access the hospital to no visitors, to occasional PPEs by healthcare providers, to everyone wearing PPEs. Is this going to be the new norm, or where is the balance going to be when the dust settles after all this?
The answer to that is depends. It depends on how the pandemic is going to progress or regress. I do believe that some of these practices are here to stay. And I do hope that with a greater ability of testing, we will be able to tailor our responses. Right now is all or none. Those policies are on all or none basis just because we do not have sufficient information to guide our intervention in a more tailored way. I do believe that a lot of things that I've spoken about that we have created in order to address the pandemic are going to stay as a new norm for us as healthcare providers.
Thank you.
You're welcome, Tom.
One last question for you. Thank you so much for making time. We received numerous questions about how you are using your advanced care practitioners and if you've increased their responsibilities and lessened oversight.
Yeah, well, we do actually. We do, we're blessed by the fact that we have very many of advanced practice providers in our complement. We all work as a team. As we're looking at a reassignment of caregivers, and we're putting people in a different position, something that they didn't used to have in the past. A really important thing is to construct those teams in such a way that we do not expose either advanced practice providers or our fellow physicians and put them in positions that are going to do something that they feel uncomfortable doing. I think it would be unreasonable to put our ophthalmologist in a charge of ventilatory support for patients with an ARDS. What we have created is a structured format when there is an oversight of a critical care physician over the large component or complement, large group of multidisciplinary team with different caregivers, so that there is always a competent person who can provide a support. But obviously the ideal would be that every person functions at the top of hers or his license. And APPs are, advanced practice providers are so valuable to us, and they have been really phenomenal in embracing this challenge.
We have one question about the financials for health systems as this extends. Could you possibly talk a little bit about the financial sustainability of academic and community and private medical systems in the US?
Yeah, financial, we're all suffering the losses, financial losses, and they come for two reasons. One, because we have suspended our elective or non-essential clinical activity. The other one is going to come a little bit later in the form of delayed reimbursement, and we're all working with a large fixed cost. And a large component of fixed cost are caregivers. There's absolutely no doubt that very many hospitals will suffer probably irrecoverable financial losses. And that's the reason why I believe that as we emerge out of this crisis, that large integrated healthcare systems that have a financial resources and then also an ability to reallocate their resources appropriately will be asked to take on even greater responsibility in assimilating these distressed, if you will, distressed assets in healthcare. We are seeing great challenges for individual practitioners. We have very many of our colleagues who are affiliated with the Cleveland Clinic. They're not our employees, but they're in a private practice. And they work in our hospitals, and we can hear their struggle. It is a real struggle to be a private practitioner right now because there are very few reserves that the small practices have that allow them to survive.
Thank you very much. We enormously appreciate your time and your expertise. So thank you very much once again for joining us. Incredibly.
Thank you very much for having me. I appreciate everything that you do. Listen, I wish everyone to stay healthy. And I know that our community will shine through this because everyone who's on this call has a unique capability, exceptional training, and also the understanding that in the moments of crisis, you need to kind of stay calm and carry on. We'll get through this.
You're absolutely right. It will transform medicine and hopefully for the better. Okay.
Oh, I'm very positive. I'm very positive. I think this is a challenging time, but I think this crisis is going to be accelerator for good in medicine if we approach it in a way that is going to be unison and uniform. And we will certainly do our best to emerge out of it. Thank you.
Okay, so now Tom Wynn is going to introduce Dr. Veena Thorani.
Brian, you want to introduce?
Yes, I will jump in. I do apologize to everyone that we're running a little long, but these talks have been fantastic and we don't want to cut anyone off. I do want to emphasize we have two excellent talks coming up, so please stay on the webinar if possible. Over the last hour, many of the questions that have been sent to the moderators have been related to treatment and trials. So thank you to everyone for being patient, waiting for these questions to be answered. Dr. Veena Thorani is well known to the cardiac surgery community. He's currently the Chief of Cardiovascular Surgery for Piedmont Health in Atlanta. He holds many high-level roles throughout our international organizations and is a national co-PI on numerous clinical trials in our field. He'll appropriately be giving us a talk on current therapies and trials for managing COVID-19 patients. Thank you, Dr. Thorani.
Great. Brian, can you hear me okay?
We can hear you.
Okay, great. So next slide, please. So this is a very interesting topic as far as we're talking about COVID. I mean, we unfortunately, we've had a huge experience in cardiothoracic surgery of being able to implement great therapies that we have, but we're at a dawn of a new virus that we necessarily don't have all the answers for. So a lot of this talk will actually be quite interesting, that I don't have direct answers for you for treatment strategies that we have, like I've given you before. This will be a little bit more of a theoretic on what we are currently trying to do. So I thought this was a very impactful editorial. Obviously, everybody I think in the country and the world knows Anthony Fauci from the United States. And I thought that he did a very nice editorial in New England Journal of Medicine. And it really talks about where we're really navigating an uncharted area completely that we've never had before in the world. And as you all know, there's a robust research effort underway right now in the world to try to figure out what to do. And therapy currently really only consists of supportive care with some investigational approaches that are being explored. And we'll go through some of those in the next 10 minutes or so. And among these are some of the antivirals, interferon, and also RNA polymerase inhibitors, some chloroquine, and other traditional Chinese medical products. But again, not very much data that we in the cardiovascular field have been so robust in providing. There are other potential monoclonal antibodies, and we'll go through a list of some of those. And then really what it really comes down to is that it's critical to move the field forward in the context of this outbreak. As Dr. Fauci said, and investigational products are really being scientifically and ethically sound studies are being looked at now. Next slide, please. I think it's important, next slide. I think it's very important that we stay grounded in what we really need to do. And this is, I thought this was a great statement from the FDA, and they released some guidance to emphasize that it's really the patient's safety should continue to be the forefront of our considerations. And we want to support the continuance of clinical trials in compliance with good clinical practice and the highest trial integrity. So for those of us that are going to be producing some new trials, and the Cardiac Surgery Network through NIH is looking at some new trials, we have to do this with the highest integrity, and really, again, with the study participants being and safeguarding these participants. Next slide. So what I'm going to go through with you really are some of the therapies, which include the antibodies, antivirals, cell therapies, RNA-based therapies, and miscellaneous, and then lastly, some stuff that we're doing at Piedmont Healthcare with Peter Barrett. So the first is the monoclonal antibodies, and this is MABs. These are used in treatments for cancer, and Ebola is really what they've been used a lot for. These molecules work as substitute antibodies, boosting or mimicking our own body's immune system to attack a virus by flagging the cells for destruction and binding to different types of cells. The majority of these are being researched for COVID-19 or in the preclinical phase, but a lot of the clinical trials right now are in progress as we speak. So the first that I'll go through is really as Temera. This is a rheumatoid arthritis, and you'll hear this over and over again that we're using a lot of drugs that have routinely been used in arthritis. This blocks IL-6 to keep it from attacking healthy tissue when the immune system overreacts. It's helped several COVID-19 patients recover, but a controlled clinical study really needs to be performed, but you may hear of this drug coming up. Avastatin is the next one. Some COVID-19 patients, a lot of these have shown to have elevated levels of VEGF, possibly due to hypoxia and inflammation. And this drug is a VEGF blocker, and it has been used to treat several types of cancer over the last 15 years. And there's currently a trial in China that's assessing its effectiveness at treating shortness of breath. So again, another drug coming in from an antibody point of view. The third of this series of drugs is going to be an monoclonal antibody that targets the pro-inflammatory cytokine GM-CSF. Its presence can elevate the expression of pro-inflammatory cytokines. Cytokines have become one of the most important targets that we're looking at for COVID-19. And this really, when you have these cytokines, it causes a feedback loop that increases inflammation, again, causing a major problem. So GM-CSF has been found to be elevated in COVID-19 patients that are admitted to the ICU. And this is not only being tested in ARDS, but also COVID-19. This is a list of 5 other monoclonal antibodies. One is Kevzara, which is at the top. Again, a rheumatoid arthritis drug that blocks IL-6. Even though the virus is diminishing, it's sending signals to the immune system to keep attacking, for which this drug could potentially stop the progress. This is, the next one is a Pro-140, CCR5 is a potential protein on the surface of WBC cells that plays an important role in the way HIV develops in the human body. And it's possible that this CCR5 receptor can inhibit the release of inflammatory cytokines. And there's a company called Cytidine that's now in clinical trials for patients, severe cases of patients with COVID-19. Again, as you see, what you're realizing is that we don't have great randomized data, and we're really having these monoclonal antibodies and other things that I'll show you are just in the preliminary stages of getting up and running. There is a PD-1 blocking antibody, a clinical trial at Southeast University in China, again, is looking at this, and they're studying the look at PD-1 and thymosin in COVID-19 patients with severe pneumonia, especially those patients who have low levels of lymphocytes, including T cells. The next is Sylvant, which blocks the action of IL-6. This has been approved by the FDA and the European Medicines Agency, the EMA, to treat Castleman disease. And the Italians are observing its effect on the patients with COVID-19. Its also hope is to reduce inflammation in those with severe respiratory disorders. So this one actually has been approved by the FDA and EMA. Next is the TJM2, and this is a part that targets pro-inflammatory cytokines, again, GM-CSF. And in 19, this drug was approved to treat rheumatoid arthritis. And now we'll see whether this is also going to be able to attack those viruses for COVID-19. So next is the antivirals. They're a therapy of antiviral degree drugs for disease like, for instance, hepatitis, flu, and herpes, many of which could potentially be repurposed to fight coronavirus. And they work in different ways to stop the replication of viruses. For example, some flu antivirals are neuraminidase inhibitors, and these are cut acids and proteins on the surface of virus envelopes, and these are releasing the replicated virus to infect new cells. So these inhibitors can reduce the amount of new viruses that are released inside the human body, hopefully allowing our own immune system to get into check COVID-19. So the hope is that some of these antivirals will stop the replication of COVID-19 once a patient's has contracted it, and lessen the duration or severity of the disease. So let's go through some of these antivirals. One is Aribidol. It's a broad spectrum antiviral that has blocks viruses entry into healthy cells by inhibiting membrane fusion. It's not approved by either the EMA or the FDA, although it's available in Russia and China, and they're obviously studying this in these patients currently. There has been some sale of this on eBay in the UK, and this is not advised at all. This should really be done through physicians and healthcare providers than being bought on sites like eBay. There's ASC09, which is a protease inhibitor, preventing newly replicated viruses from maturing and invading healthy WBC cells. There's a China-based biotech company that's testing this in clinical trials now. Azividine is a nucleoside reverse transcriptase inhibitor. HIV uses the enzyme reverse transcriptase and reverse transcription, converting RNA into DNA. This inhibitor blocks this enzyme. And so there are clinical trials now in China looking at this exact drug. A lot of these now are coming to the USA, and the FDA is releasing a lot of these trials in the United States through a fast track mechanism. Favipiravir is a broad spectrum antiviral that's been utilized in Japan to treat flu by inhibiting viral RNA synthase. It's in clinical trials now, and patients who have received this tested negative for the virus after a median of 4 days, and those who did not took 11 days to test negative. So it really decreases the time that we're having this syndrome. There are 2 or 3 more. I'll concentrate on the bottom 2. This is Caltera, which is a combination of a protease inhibitors that you see there, and they're used to treat HIV. There's a high urgency for the WHO to look at this drug, And New England has results of a study of 199 patients with this drug in severe COVID-19 patients in China. And those who received it saw no difference in mortality, but they did see a decrease in symptoms. Remdesivir is also the drug that's gotten a lot of press. It's a broad spectrum antiviral, and it's been studied as a treatment for MERS and also respiratory illness that is caused by the same family of COVID-19. If you remember MERS we had a couple of years ago from the Middle East. Some experts are hopeful that it will have more luck with COVID-19 than it did with MERS, and there are several clinical trials underway for this. There are two more type of antivirals. We won't go through the details for these, except to say that there are trials going on for a Truvada, and people have heard about this in commercials for HIV as a preventive pre-exposure prophylaxis, and also this is now being looked at COVID-19. And lastly, for this is an endonuclease inhibitor, or endonuclease is an enzyme that initiates flu virus replication, and these Xofluza is an inhibitor of this, and there are trials ongoing for this for specific patients who already have pneumonia in COVID-19. So there are some cell and RNA-based therapies. The cell therapies are mesenchymal stem cells, which are adult stem cells, and they can be taken from either humans or animals. Pneumonitis, as we know, is a side effect for COVID-19, and there's thought about maybe treating patients with MSCs to treat lung damage caused by radiation. And there's also Multistem is a study or a company looking into this, and there is a fast track for a clinical trial testing this for COVID-19. There's RNA-based therapies that are also coming up in preclinical phases. So now there's what we call miscellaneous studies, and I'll spend a little bit of time. There's a list of a couple of these, but I will skip the first one to maybe go to the second one, which there's been a lot of attention played to, which is hydroxychloroquine. And let's talk about these. These are two anti-malarial drugs that have gotten a lot of attention. However, the efficacy in COVID-19 is not known. Remember, malaria is caused by a parasite. COVID-19 is a virus. The reason that some researchers are looking at these drugs as potential is that chloroquine and other drugs were able to block coronaviruses, not COVID-19, but coronaviruses from infecting cells in laboratories during the MERS 2012 outbreak. And the mechanism hypothesis is they change the cell surface acidity so the virus can't infect them. And so chloroquines may activate also the immune system in itself, and there are a few clinical trials looking at this, and I'll show you some slides on this next. So the one study that has looked at this, it was published in RxIV 2020, is one from China, and you'll see on the next slide that this was the first randomized trial looking at this, 142 patients which received hydrochloroquine, you can see on a daily basis. It turns out that there were 31 patients in each group. This was a randomized trial. The next slide shows some of the differences between the patients. You can see the age is young, 44 and 45 in each group. And when you start to look at some of the data, which on the next slide I have more of the results, but you can see that there's a decrease in a lot of the symptomology that occurs. And this is the absorption on the bottom right hand, it's the absorption of pneumonia on chest CTs is significantly better with the drug than without the drug. On the next slide, you can see that the key findings for the 62 patients who had it, 47% of patients were male, 53% were female, mean age was 44. And towards the end, you'll understand that basically the larger population of patients had improved pneumonia with treatment, 80%, compared to the control group, which was 54%. So really, notably, all 4 patients progressed to severe illness that occurred in the control group, and there were 2 patients with mild adverse reactions in the treatment group. So really, we're seeing at least a 30 to 40% increase in absolute numbers for therapy using this. Again, a very small randomized trial. Next slide is a warning from the CDC. This is a chemical that is used in home aquariums. People have died from taking this. Please do not do this without having healthcare providers really prescribe this and watch you very carefully in taking this drug. There are some losartan, and also prednisones, which are being looked at carefully. The idea is that angiotensin is a peptide hormone that constricts blood vessels and raises blood pressure. It's possible that these have some effect on COVID-19 patients, and the same with methylprednisolone. Antibiotics, azithromycin, colchicine, and these have been looked at. There is no good data for this. These are all being studied right now, especially azithromycin. I know all the pharmacies have almost run out of this drug. And colchicine, people there are no good data for this, but the thought is that really on the antibiotic side, that this will prevent super infections, and that's why people are using it. When it comes to the colchicine, there is a new study of 6,000 patients that are going to receive colchicine versus placebo, 1-to-1 allocation for 30 days to see if we can decrease some of the death rate and lung complications. And then, of course, there is also some trials based from the positive results of JAMA Internal Medicine on MPs, which showed a positive effect on survival in the SARS-CoV-2 critically ill patients. So therefore, there's a new trial coming on. The pathway is 80 milligrams of IV bolus, followed by 80 milligrams in 240 cc's of 0.9% saline infusion for at least 8 days or until the PCR is less than 20. And then MP 16 milligrams BID, slow tapering until the PCR is normal range. So what we've been doing, we've been trying to decrease the inflammation and support. I give a lot of credit to Peter Barrett, who gave me information for the next couple of slides. And he is the leader for our, he's a cardiac surgeon who is really running our cardiac intensive care units, a phenomenal individual. And he is obviously treating most of these patients on ventilation mode. We've had 6 patients who are on ECMO. One of those patients has survived and is on the floor. The other 5 are undergoing ECMO, and hopefully one will get decannulated today. But he's mainly using ventilation and then bronchoscopy with bicarb in order to clear the secretions. He's using zinc, hydroxychloroquine on a daily basis. He's using erythromycin and also leukotriene inhibitors, and really treating these patients. As he bronchs them, they're really like CF patients, where he's seeing a lot of mucus as far as the bronchoscope will allow to go. He is also working on nutrition, and ECMO is needed. And I think the next slide goes a little bit through the ECMO. Okay, that's it. So I think we'll stop there for now. I know that's a lot of information, and hopefully we'll be able to digest some of this and get some data to actually guide our physicians instead of anecdotally treating them. So thank you, Tom, Brian, and Joe, for having me talk about this.
Dr. Thorani, that was, as expected, an unbelievable talk with a great overview of all the trials and options that we may have down the road. We have time for one question, and I know you were just briefly going to talk about it, ECMO. Who should be getting it right now, and why aren't we seeing better results for patients that are being put on ECMO?
Well, as you well know, ECMO, the results of ECMO across the board, we usually wait too late, right? And the results of ECMO have been very difficult to decipher. And I think that we're going to start to get an idea of what are the best patients, but our indications are patients with severe reversible hypercarbia, severe reversible hypoxia, those that do not have end-stage disease process. I think we have to hit ECMO earlier than later. And those are really the patients that are going to have the best chance of having a success with ECMO. If we get them in the dialysis phase or other type of phase, I think or liver failure or heart failure, I think we're going to have them not do very well. So we have to be very thoughtful in how we can get these patients earlier on ECMO if ventilation is not working well.
Great. Thank you so much, Dr. Thorani.
Thanks.
So to everyone out there that's still watching, we're going to try to wrap up in about 15 minutes. We have one excellent talk left, and I'm going to turn it back over to Dr. Chikwi to introduce.
Thank you very much, Brian and Vina, for a phenomenal talk. We have 100 people still watching, and we've saved one of the most valuable topics to the end. So good morning, Dr. Chinua Achua. Thank you very much for joining us. Dr. Ancha is an emergency medicine doctor serving in the Bronx in New York City, which has been one of the hardest hit communities in the US. His topic today is Ground Zero in New York, our hospital before and during surge. What have we learned? Somebody needs to unmute Dr. Ancha.
Just hear me?
Yep, we can hear you.
Thank you.
Okay. Nice to meet you guys. I'm actually an emergency doctor at Brookdale Hospital in Brooklyn, which is another hard-hit area, as well as South Bronx and Queens, basically all the boroughs. I got asked to come into the fold of this conversation. I know Dr. Isaac George from humanitarian mission trip we did together to Haiti back in 2010, 2011 after the earthquake. And I was a med student back then, and he was a resident. I was assisting him doing BKAs in the rooms down there. And so it's kind of a interesting surprise when he asked me to come along and do this. So a lot of you guys know about in the news about hearing about the USNS Navy hospital coming into New York to help out. It's a 1,000-bed hospital with about 80 ICU beds, 12 ORs, and a lot of people were looking forward to this coming and providing relief. And right now it's only housing about 20 patients. And there's a lot of frustration on the ground between hospitals and providers and the government about how come we're not utilizing those resources as much as we can. And we're still trying to figure out how to do that. You already have a hospital tent that's getting hospital tents getting set up in Central Park by the Samaritan's Purse organization, which comes with a lot of controversy itself for other reasons, but it's a 60-bed hospital with 20 ICUs, and it's trying to help provide some relief for the Mount Sinai healthcare system. You go to the next slide, please, Tom. So this is a picture my friend took outside of Mount Sinai Hospital out of his ER. You can see the ambulances lining up and down the street. So my background is I've been working throughout this crisis from the very beginning. Before it even started, there was a lot of hysteria, and the ERs were kind of actually, I remember my first few days, the ERs being kind of quite empty. A lot of people were scared to come to the ER. There was a lot of hysteria in the news. People were starting to stay at home, and we started having our first few cases trickle in. Now we only have 2 or 3 air droplet precaution rooms in our ER, and those got filled up pretty quickly. And in the next 24, 48 hours, we're seeing all our monitored rooms on one side of the ER and another dedicated 5 or 6 monitor rooms on the other side of the ER and become isolation zones. So we went from 3 or 4 rooms to basically about 15, 20 rooms becoming designated COVID isolation rooms. And the next 24, 48 hours after that, we started having patients just flood the hallways. And so now we have COVID patients that are not in the isolation zones that are just sitting in the hallways. And then finally, the next week or so, we're having to shut down our pediatric ER. We're gutting other areas of the first floor of the hospital to become COVID designated areas. We're taking the social workers' rooms and turning them into covert areas. We're taking the area where the hospitalists come down to work and taking all the computers out and gutting that into a COVID area. And so we've become really overwhelmed and inundated with patients to the point where you're seeing in this picture, we've had ambulances literally line the hospital outside of our triage. And there's literally a 3 or 4 hour wait for patients to come through the triage from an ambulance. And the other night I actually went into an ambulance and actually intubated a patient because there's no space in the ER. And that's how dire the situation's become. Every hospital is going on diversion, and diversion is what emergency rooms and hospitals will do when the ICUs are all filled up. There's no monitored beds in the ER. Every hospital's on diversion, and FDNY cannot let every hospital go on diversion. And so it's becoming a very tricky situation to maneuver around. I'm literally going to the ambulance triage and discharging patients from ambulance triage or telling them go home, telling them, listen, your complaint isn't serious enough. I'm sorry, we can't look at, your mild complaints today. You need to go home. This is not a place for you to be here. And we're trying to advocate this to patients, and a lot of patients are listening, but some are still coming. And the important thing is, if you're coming to the emergency room, you have a high risk of contracting COVID. And that's really our concern, is that we're trying to keep the ERs prioritized for people who really need them. That isn't to say that we're still getting other emergency cases, but for the most part, people are listening. But we're literally going to ambulance triage and telling patients to go home from there. I've had to tell seniors, other senior patients that are in their 70s or 80s who've been sitting in the same chair for 24, 48 hours straight, hey, you can't, they're asking me, can I please get a stretcher, doctor? I really need to lie down. And I'm telling them, I'm sorry, I can't give that to you. And it's really disheartening because, these are older patients, they're not young like us, and they've been there for literally 24 hours. And I have to tell them, I have to give these beds to patients that are delirious or can't walk or confused because they're fall risk. And I'm sorry, I can't do that for you. You know, sometimes the police will bring patients to our ER because they have, you know, for different reasons, for patients that are arrested or they're prisoners. And I've had to I actually scolded 2 police officers for bringing a patient that didn't need to be there. You know, so we're just doing things that we're under high stress that we're not really used to doing. And it's a very high stress environment in the ER right now. You can go to the next slide, please, Tom. So here's a map of Manhattan that sort of gives a lot of where most of the high concentration of cases are appearing throughout the city and in the boroughs. And you can see Manhattan, you know, it's still having a fair number of cases, but a lot of these congested areas like the Bronx, Queens, Brooklyn is becoming flooded with more cases. And it's, you know, that's where you tend to see more of the lower income population that are living in more congested areas. So it's not a surprise that we're getting a lot of more cases out there in the boroughs than actually in Manhattan. Go ahead, you can go to the next slide, Tom. So my hospital actually ended up, CNN actually ended up showing up to my hospital, and this was probably a few hours after my night shift ended. And this picture actually does it a little bit more justice. It looks a lot more worse than this. I don't think it really shows how bad it looks inside there, but you see this hallway right here. And I can tell you, I walked into my shift the night before, and right behind this nurse that's walking through, I literally coded 2 patients in this hallway itself walking in because people's oxygen tanks were not getting checked. And people were literally in bed going apneic and going pulseless, and they were just being found dead in their stretcher. And I did this with 2 people on this shift right before they showed up. And, you know, it's something I've been trying to advocate with our colleagues, and we've been trying to make sure other ER doctors do, is you literally have to get up and go check out all the oxygen tanks every hour. I mean, we literally have 20 or 30 people on oxygen tanks all around the ER. And, you know, you forget about one person, you know, you put a lot of risk on what happens to them later. And so we're literally changing about 10 to 15 oxygen tanks every 3 to 4 hours. And we just don't have the resources or the supplies to, you know, have people check on these tanks. So the doctors we're trying to do them ourselves. You know, I literally on this shift, I had a 32-year-old come in, and, you know, they have their classic look of bilateral opacities or infiltrates on x-ray. You know, they have the lab markers. They look like they have COVID, but they're walking around. They're not dyspneic when they're walking around. Their vitals are okay. And, you know, I watch this 32-year-old for 3 to 4 hours. And all of a sudden in the last hour, his pulse ox drops to 60%. And I have to kind of carry him over to the asthma room, which is the only area we have left. Then I'm putting on oxygen over there at 4 liters or 5 liters nasal cannula. And these are the kind of things we're seeing in young people and old people as well. Go ahead, you can go to the next slide. This is a doctor that passed away recently in our field, Dr. Frank Gavrin. Very well known among my colleagues. I never had the pleasure of meeting him, but he passed away a few days ago. He was experiencing mild symptoms for about a week, and then he just developed acute sudden onset respiratory failure at home and actually passed away in his husband's arms. And, you know, he was very well known in the community because he was very all about, you know, addressing physician burnout, about physician wellness, about addressing your mental health as a doctor. And a lot of people respected him for that. And this was a post he put on his Twitter literally 3 days before he passed away. So you could see how sad and overwhelming it was for a lot of us to see this happen. And you know, because of what's happening, a lot of the older doctors and even other providers, nurses are sort of trying to avoid the emergency room, and with good reason. I mean, you know, they have their own ailments and they're more at risk for being exposed. And so a lot of us younger doctors are trying to step up and fill in this need at the same time. Go ahead, you can go to the next slide, Tom. You know, I don't know, you know, we're gonna have this conversation when everything boils over, you know, and maybe it's too soon to talk about it, but, you know, I really feel, a lot of us feel that there's a big failure in our healthcare system and government as a whole in addressing this. You know, personally at my hospital, it was really frustrating for our hospital CEOs or administrators to be so resistant to open up more space in our ER. You know, we knew about this about a month ago, but for some reason, you know, in just the days leading up to these sudden surges that were happening every 24 to 48 hours, why weren't these spaces becoming more readily available? You know, there was an article about how the CEOs of Mount Sinai, and they're dealing with it a little better than we are, were in Florida through this through this whole pandemic at, that their homes in Florida. On the right, there's these nurses in a Midtown hospital started using garbage bags as PPE, and that caused a little bit of an uproar. And I can tell you from my experience in my hospital, the lack of PPE was a huge issue. Before the hospital started addressing this and trying to really procure all the PPE in the hospital so it could be rationed out more. There had been a few staff members that had gone rogue and actually stole boxes of these supplies from the supply room. We're having residents and nurses almost arguing every morning about, why can't I get this PPE? Why can't I have this PPE? And it feels like there's a lot of low morale going on. I can tell you as a provider and a lot of my colleagues, most of us are probably exposed and infected with this. There's no way, we're working in our environment and we're having the proper protection against what's going on. I mean, we're being made available PPE, but there's so many patients laying everywhere in the hallways right in front of us that we've made a decision to take care of our patients before worrying about our own exposures sometime. I can tell you about one patient I had sitting in front of my desk for literally 2 or 3 days who was boarded in the ER. It was sitting there for 48 hours. The rooms upstairs are full, so I keep coming back to shift and seeing him there. And it was 4 or 5 hours into my shift till I noticed that he had taken the cups from the water fountain and set them on my desk in front of me and put his dentures in them. And, I'm sitting back thinking, okay, if I don't have it now, I definitely have it at this point. And, I had a colleague, I came in to take over, sign out from a shift, and he was telling me, I'm eating these Cheetos and I can't smell anything. I can't smell or taste these Cheetos. And, a lot of these patients are coming in with anosmia where they're not able to smell or taste anything. And, we know, we're all getting this, but what are we doing? We're accepting this principle of herd immunity at this point and just trying to take care of our patients. So, and there's another issue about also testing. We were sending our tests initially to the Department of Health, getting permission from them first. So these tests were coming back 24, 48 hours. Now we're able to get tests back done in the same day, but they're taking 12 hours or later to come back sometimes. Other hospitals in the city like Northwell, every hospital in New York is sort of developing their own test, which it brings up this issue of allocation of resources. Urgent cares that are affiliated with Northwell are actually doing rapid testing in urgent cares, which you want to think, why are patients walking to urgent care is getting a test? If you're worried about these patients having COVID and developing worse symptoms, they should be transferred to a main hospital. And so I think the question of who should be getting testing when we have scarce resources is going to come into play later again too. Go ahead, you can go to the next slide, Tom. So just a little few stuff on the medical part. So a lot of what we're doing is using high flow nasal cannula. We don't have high flow nasal cannula in my ER personally, but they are being used in other ERs. What we're doing in my ER is using nasal cannula and a non-rebreather over that. And ideally you want these patients in isolation areas or in rooms so the virus isn't getting aerosolized throughout the ER. Now, again, unfortunately, at my ER, I don't have that luxury. I can have patients get hypoxic, or I can treat them with this and suffer the consequences of that. We can't do ABGs on every single patient. So on this left here, we have this apparatus where how are we pre-oxygenating our patients when we're intubating them? And we developed this equipment where we have a CPAP mask attached to a vial filter and an ambu bag. And the idea is to create a really good tight seal with that ambu bag and to bag the patient so you pre-oxygenate them enough. And we're not using direct laryngoscopy, we're using video laryngoscopy because it decreases our exposure to the patient's secretions and airway. You're kinking the ET tube, meaning you're bending the ET tube so when you're changing the ambu bag to the vent, you're not letting that expose into your face if you're intubating. On the right is actually an apparatus that was developed years ago that was used by an emergency room doctor in Las Vegas during the mass shooting 2017. I'm sure a lot of you are seeing this on social media or have heard about it, and it's using the concept of sharing shared ventilators. We've had to do this once in our ER, and the idea is you take a T-tube and then you attach 3 or 4 separate E-tubes on the side, so you can basically put 4 patients on each ventilator. And so you're really trying to use what you have to help everyone. Why save one when you can save four? And a lot of the ventilator strategies that we're encouraging is, using like pressure cycled mode as opposed to a volume cycled mode, because, you don't have to, you want to make sure that you don't have to just deliver the same amount of tidal volume to every patient. You want it to more depend on compliance. You don't want the patients to be triggering the vent, so you want them on a continuous mandatory ventilator mode. And you want the patients that generally have a similar PEEP and FiO2 on the same ventilator. So if you have patients that are requiring high amounts of PEEP, if they're in ARDS, or if they're requiring a high amount of FiO2, 100%, you generally want those patients together on the same ventilator. And you want these patients deeply sedated. So those are some of the ventilator strategies we're trying to use. Lastly, some of the medical workups we're doing, we're using a lot of inflammatory markers, non-specific inflammatory markers like ESR, CRP, LDH, and ferritin. And we're looking at our x-rays, and we can generally tell when a patient is COVID positive from this workup before sending the swab out. We're advocating a lot of gentle hydration of fluids, nothing more than 500 cc's of fluids. If a patient's hypotensive, not to go through your normal sepsis protocol if you're suspecting COVID or ARDS, but to start pressors early, like Levophed or anything else, and to really avoid giving that 20 cc or 30 cc bolus of fluids. We're encouraging use of IV Lasix in patients that are over fluids. We're not using steroids. A lot of our literature is showing us to not use steroids in these patients, except for very certain subsets of sepsis. And a lot of you will know that when patients are generally on 2 pressors or more, you will start steroids on septic patients, but we're asking clinicians to be even more judicious about using this. We are using azithromycin and chloroquine, and we're, there's a lot of literature even from third world countries. I know a lot of the speakers before were talking about, chloroquine is something that was used a lot that is manufactured and used more in other countries where parasitic infections are more prevalent. And so you're seeing a country like us where we have a shortage compared to countries like other third world countries like India or China that have more of this readily available. And so we're putting, a lot of patients that we're discharging from the ER that we're saying are safe to go home, we're putting them on Z-Packs. And so, the road is really tough, and we are adapting a lot, but we're learning a lot and we're getting better at this. And so this is the x-ray that a lot of us are getting used to seeing every day. I'm probably seeing 10 to 15 of these every day, and we're getting really sick of seeing this every day. And I definitely encourage a lot of you that are working in the field or working on this to just, really make sure that you're avoiding burnout, that you're keeping your mental health prioritized. It's a very challenging situation for all of us, and hopefully there will be an end in sight. Thank you guys very much.
Chinyu, thank you so much for absolutely frontline, real-time understanding of what this means to be a care provider. One question really for you. What PPE are you wearing on your shift working on these patients, and what PPE should you be wearing?
We are being made available shield visors, N95s, and surgical masks. So we're putting an N95 over us, then we're putting a surgical mask over that and a shield mask over that. And we're just using the same equipment for the whole shift. Sometimes we're using it for 2 shifts, but really you shouldn't be reusing this stuff after seeing multiple patients, especially for intubating patients, because that's when you have your highest risk of aerosolization of the virus. But it's coming down to just rationing supplies and using what we have.
And how are you dealing with patients? I spoke to a physician in Queens. Essentially, the entire CCU is intubated patients, all on 3 pressors, all needing dialysis. They don't have access to dialysis. They don't have enough high flow oxygen. How is your hospital managing right now?
It's kind of trucking along. We are, there's so much going into play about which dialysis can be used for COVID patients, or where can we put these, all these intubated patients. They're literally just everywhere in the ER. I mean, for every 2 people who are putting on a vent, 1 person is coming off, passing away. And we haven't run out of ventilators yet, but we're getting there. And it's very dynamic. It changes day to day. We were sending some COVID patients to another hospital for dialysis, and now they're coming. Now we've decided to change that. We're not sending patients to cath lab as much. We're trying to do TPA more. We're trying to do, just manage with what we have for the time being.
So if you had one message for an ED or one message for a hospital that's preparing to face this, what would it be right now?
Take all the signs very seriously. I've spoken with a few friends that have said that their ERs are very quiet and eerily quiet. And it's almost like an early forewarning of things to come. I think you expect people are scared not to come to the ER right now, but I don't know how things are going to change after this is all done. I know we were talking about this before, that we all live far, most of the US is kind of far apart in terms of you have to sort of drive everywhere you need to get to. We don't have high transit systems, but who's to know what to say how these infection rates will affect the suburbs and rural areas later on. And so I think it's always, good to be judicious and just prepared. Hospitals should have contingency plans in place. Where are you going to put your overflow patients? How are you going to manage the other emergent services like cath labs, surgeries? And so my message is definitely preparation.
Yeah, so securing the supply chain seems to be number one. Number two is making capacity. Sheena, thank you so much. I want to thank the entire CTSNet team for hosting this broadcast, and to all our speakers for finding time in packed schedules to give us some superb insights. We will be providing answers to many of the questions that were asked on the chat on the CTSNet resources page for COVID. These are really challenging times. They will be transformative, and you all can be architects of that transformation. So stay well, be safe, and please get in touch with Brian, Tom, or me with all of your feedback on this first, I hope, of Global Grand Rounds. Thank you very much.